Thank you for the invitation to speak today. My topic is women with epilepsy from preconception to postpartum period. As we know that epilepsy management in women is a partnership between ONG and neurology. But today, I'll focus mainly on neurological management in women with epilepsy. First, I'd like to start with definition of epilepsy, the latest in 2014. As we previously know, anyone with 2 seizures or more, we can diagnose them as epilepsy. However, with these new definitions, if someone have only 1 unprovoked seizure, but with a recurrent risk of more than 60%, this is adequate to be defined as epilepsy. Who are the people with recurrent risk of more than 60%? Are those with abnormal imaging, abnormal EEG, positive family history, or after second seizures, or in those with cognitive developmental disability. In 2017, there is also a new classification of seizure types. In the past, we call focal seizure as partial onset seizures, and the simple partial seizures is now called focal aware seizures, whereas complex partial seizures is called focal impaired awareness seizures. I'd just like to highlight a few seizure types which can be misleading. The first one is automatism. Some people have lip smacking and swallowing or lips movement. We'll call this oral automatism. However, if their movement involve the limbs, like playing a drum, unbuttoning their shirts, combing their hair, we'll call this limb automatism. Another seizure type is hyperkinetic seizures, which occur mainly at night in those with frontal lobe epilepsy. They can be very violent with kicking and rocking or cycling. And we may thought this is sleep terror, but they are very stereotypic and they are in fact a frontal lobe seizures. Other features suggestive of focal onset will be aura. I'd like to highlight the difference between psychic aura in normal people in people with epilepsy and normal people. For example, in deja vu. So deja vu in those with seizure are very intense, very difficult to get rid of, and at times it precedes seizure, and they are very stereotypic. Why is it so important to differentiate focal and generalized epilepsy? Is because in focal epilepsy, 40 to 50% of them are refractory to anti-epileptic drugs, require more management options. In this group of patients, if they wish to get pregnant, we will still support them despite having uncontrolled seizure. Similarly, in 2017, there's also new epilepsy classifications, mainly the classifications of etiology. And from here, we know that those with structural origins or infectious origin, or even with some with genetic origins, they may have very poor response to anti-epileptic drugs, and up to 40–50% may have been refractory to anti-epileptic drugs. So I'd like to start with this case. Number 1, a 16-year-old girl with 1 episode of generalized tonic-clonic seizure in school, given phenytoin by GP. She developed early morning myoclonic jerks. We will call this myoclonic seizures. EEG show generalized discharges, and therefore the diagnosis is generalized epilepsy, or a specific syndrome will be juvenile myoclonic epilepsy because of the juvenile onset and predominant myoclonic seizures. The best treatment for this group of patients will be sodium valproate. However, there is a few concerns. The first concern will be cognitive impairment in those with fetal exposure to sodium valproate. The IQ of the children when the mother is exposed to valproate is lower than those exposed to carbamazepine and phenytoin. And the follow-up study at 6 years old also shows similar lower IQ in those who have been exposed to intrauterine sodium valproate. These are dose dependents, especially those who are more than 800 milligrams daily. Their IQ is 9.7 points lower. Because of this, the NPRA Malaysia has added a package insert in 2015, which stated that Epilim should not be used in female children, in female adolescents, and in women with childbearing potential. In addition to lower IQ, teratogenicity is also a problem. This chart with the black color fonts are from the North American Pregnancy Registry, whereas the blue color font are from the Cochrane Review in 2016. And you can see that sodium valproate in fact had higher teratogenicity risk as compared to other anti-epileptic drugs. The second one I would like to highlight as well is topiramate, and I have a patient with topiramate deliver a baby with cleft palate. However, the lamotrigine, levetiracetam, and zonisamide, or even carbamazepine are relatively safer with lower teratogenicity risk. And the risk itself is dose dependent, similar to those affecting the IQ in the fetus. There's also a risk of automatism with sodium valproate as compared to other anti-epileptic drugs. This should be bear in mind. Therefore, an expert opinion has been developed in 2021 this year, especially on valproate use in women with childbearing potential. So for someone with newly diagnosed epilepsy, before menarche, we can consider sodium valproate. In fact, we should strongly consider that, but we need to switch the sodium valproate when they are older or when they are in the childbearing age. However, for those after menarche, we can counsel them, especially for those with low childbearing potential and no plan for pregnancy, sodium valproate can still be used. However, if someone has a plan for pregnancy, we should consider other anti-epileptic drugs. Therefore, in this group of patients, we usually counsel them regarding pregnancy best if their seizures are free. However, as I mentioned just now, 40 to 50% are refractory to anti-epileptic drugs, and they may have uncontrolled seizures while planning for pregnancy. Another point to highlight is that if there are no other suitable alternatives valproate, we can initiate valproate. However, if there are, then we should consider other choice of anti-epileptic drugs. In juvenile myoclonic epilepsy, however, sodium valproate is still the best options. Therefore, we will explain the risk to the patients, especially stating that the risk will be lower if the dose is lower, or the patient is on monotherapy, or they are on less teratogenic anti-epileptic drugs. We will also explain the need of contraceptions if they are sexually active, and will need to inform us if they have a plan to get pregnant. Usually, it takes about 3 to 6 months to switch sodium valproate to another anti-epileptic drugs. This is a chart listing the drugs which has less teratogenicity risk, as I mentioned in the chart previously. Here, it demonstrates the total number of major congenital malformations in the yellow bar. And we can see that lamotrigine, levetiracetam, and oxcarbazepine has a teratogenic risk of about 3%. How about carbamazepine? When the risk is compared to the lamotrigine, the odds ratio is non-significant if the carbamazepine dose is less than 700 milligrams. Therefore, lamotrigine low dose can still be used in those who have a plan to get pregnant. In fact, the total risk is about 3 to 5%. What if someone is already on sodium valproate and we plan to withdraw during pregnancy? In this study, it shows that for those who want to withdraw sodium valproate, there is a 33% chance of developing generalized tonic-clonic seizures during pregnancy. This is compared to those who continue sodium valproate with a 16% risk of having generalized tonic-clonic seizures. The difference is as big as 17%, and therefore we must inform or remind the patients to be aware if they have a plan to withdraw or switch the sodium valproate. There might be risk to the baby or causing miscarriage to the pregnancy, or there may be a trauma to the mother. More importantly, sudden death may occur if the seizure is not controlled during the dose adjustment or dose or sodium valproate withdrawal. Therefore, we must weigh the risk against the benefits of avoiding teratogenicity effect. How about fertility? In this very old study in 1998, it shows that the live birth in women with epilepsy is 25% lower than in women in general. Why is it so? It may be because of social stigma or fear of inheritance. In fact, in the Malaysian social stigma study, it shows that 62.5% of women with epilepsy were single as compared to 35.9% in their siblings, with an odd ratio of 3.0. Other problems including cosmetic effect of anti-epileptic drugs, including obesity and alopecia. Menstrual irregularity may also occur in up to 20 to 60%, depends on various studies. And one of these is related to sodium valproate causing polycystic ovarian syndrome. Enzyme inducers such as carbamazepine and phenytoin may also interfere with the reproductive systems. And similarly, seizures can also have an impact on these systems. Weight gain is in fact very common. However, for those on topiramate and zonisamide, they may have weight loss. Regarding polycystic ovarian syndrome, which is a common problem in normal populations up to 4 to 6%, it is even more common in those with epilepsy. Whereas for those on valproate, the risk can be as high as 60%, but these are reversible. I would also like to touch on catamenial seizures, which is seizures occur predominantly before or during menstruations. This is related to the pro-convulsant effect of estrogens. This occurs in about 5 to 12% of women with epilepsy, and the treatments will be intermittent benzodiazepines or acetazolamide given during menstrual period. How about contraceptions, especially those on enzyme inducers? Most oral contraceptions need to be either increase the dose because of the enzyme inducing effect, or intervals being shortened, especially for intramuscular Depo-Provera. However, I would like to highlight Lamotrigine, which metabolisms can be affected by estrogen-based oral contraceptions. Therefore, for those with oral contraceptions, Lamotrigine level may drop and seizure may occur during this period. Whereas for those with non-oral contraceptive methods, most of them has low failure rates except intramuscular Depo-Provera, as I mentioned just now. This case is related to planned pregnancy. It occurred to the same girl who is now 23 years old with juvenile mild chronic epilepsy, and her sodium valproate is 400 milligram BD. She has been seizure-free for 7 years, and she's now married and planned for pregnancy. So what should we do for regarding the sodium valproate? These are the recommendations based on the expert's opinion guideline. Firstly, we should counsel the patients consider reducing the dose of sodium valproate to less than 600 milligrams per day, or switch to another anti-epileptic drugs. As I mentioned previously, we usually take 3 to 6 months to switch over and observe the seizure control after the switch. This is another patient with refractory epilepsy, which we have monitored recently in our video EEG monitoring. She's a 39 years old Indian female with seizures onset at 21 years old. Her seizures are mainly consist of fear, oral automatism, right hand automatisms, and left hand dystonia. These etiology are very typical for temporal lobe epilepsy, which was supported by the EEG, which show right temporal ictal and ictal discharges, and MRI showing this right hippocampal lesion, which is right mesial temporal sclerosis with a hyperintensity and atrophy of the right hippocampus. So the diagnosis is right temporal lobe epilepsy secondary to mesial temporal sclerosis. She has tried 3 anti-epileptic drugs, including carbamazepine, lamotrigine, and levetiracetam, but it doesn't seem to control her seizures. Although we know that these 3 drugs has very low teratogenicity risk. Her seizure is now once per week, but she still plans to get pregnant. So what will be your plan? Shall we try more newer anti-epileptic drugs? As listed in this chart, zonisamide is in Malaysia since 2000, whereas latrosamide and perampanel is in Malaysia since 2010 and 2012. And you can see here that there is an exponential increase of number of newer anti-epileptic drugs since the year 1990. However, we know that people who have failed first or second drugs, the likelihood of the seizure being controlled with the third drugs is only 4%. And in total, 36% will not be controlled. And for this patient in particular, the chance of her to have seizure control will be as low as 3 to 4%. Therefore, we should consider epilepsy surgery. In our cohorts, we can see that 40% of our focal epilepsy are refractory to drugs. For those who has performed surgery, 60% are seizure-free. Especially for mesial temporal sclerosis, we can achieve even as high as 70 to 80% seizure freedom rate. And this way will consider a cure for those with epilepsy. This will require teamwork to do pre-surgical evaluations, and we need early referral if someone is having uncontrolled seizures. So the patient I told you just now had her epilepsy surgery performed in March, and she is seizure-free until the June in the last review in June. And she will plan for pregnancy next year if she has no more seizure for at least a year. In Malaysia, we have started our intra-invasive EEG monitoring, especially stereo EEG in 2019. This is a very specific methods, especially for those with no lesion in the MRI or multiple hypotheses of where the seizure is coming from. As you can see here, the electrodes here are very tiny, and it was inserted into the brain through a burr hole, and it helps to record the epilepsy activities and network through EEG recordings. It is very useful for bilateral implantations. It can be done both left and right, multiple lobes, as well as for deep structure such as insular and cingulates. How about unplanned pregnancy? If for the same girl who is now 23 years old on sodium valproate 400 milligram BD, and if she come to you with 8 weeks pregnant, what shall you do? So this is what recommended by the expert opinion as well. If the seizure is controlled, usually we shouldn't change the drugs and should maintain the sodium valproate as the dose as it is. But if the seizure is uncontrolled, then we can consider switching the medications to another anti-epileptic drugs or add on a new or another agents. The recommendations in the books stated that we should inform the patient about the teratogenicity risk, which is relatively less likely to happen after 8 weeks. If a major congenital malformation is going to happen, it will occur within the 4 to 8 weeks of gestations. So there is no point to switch the sodium valproate to another drugs if the patient have good seizure control. You just remind them to take folic acids and can consider normal vaginal delivery if the seizures remain controlled throughout pregnancy. So how about lamotrigines if we have switched the drugs to lamotrigine in these patients? So let's say the patient's seizures is not controlled with sodium valproate, and we have switched to lamotrigines. And the seizures is controlled with lamotrigine up to 100 milligram BD. However, during 16 weeks of gestations, she had one generalized tonic-clonic seizures. So what shall you do to the lamotrigine level? So we know that lamotrigine level drops 50% in second or third trimesters. This percentage represents the relative percentage compared to pregnancy level. And at weeks 11 to 20 of gestations, you can see a drop of almost 50% in the lamotrigine level, which maintain up to the third trimesters and will improve or return back to the original level after delivery. In Malaysia, we'll try to do lamotrigine level if the seizure is uncontrolled, especially during second trimesters. This you can send to Gribbles and it costs about 200 ringgit and the results will come back 2 to 3 weeks later. Now I'd like to talk about status epilepticus. Status epilepticus is actually very rare, but there are many causes, including eclampsia, but I'd like to highlight autoimmune limbic encephalitis. Prior to that, I would like to inform this specific paper on uniform treatment protocol by the same group who has written the previous paper as well. The treatment for eclampsia will be the same, but if it's not eclampsia, then the treatments will be similar to those who are not pregnant and having status epilepticus. We always started with benzodiazepine, followed by second line, which include phenytoin, phenobarb, or levetiracetam, as recommended in this protocol. Steroid and immunoglobulin should be considered for those with autoimmune origins. Autoimmune encephalitis can be positive or seropositive or seronegative. It usually presents with limbic presentations, including psychosis, and sometimes the patients may have seizures or orofacial dyskinesia. This combination of three presentations are usually supportive of diagnosis of autoimmune limbic encephalitis. To confirm the diagnosis, we'll need to send the serum or CSF for antibodies. In Malaysia, we can send to KBJ link for autoimmune limbic encephalitis panel. Most often, the EEG will show slow wave. However, the CSF and MRI will be normal, and the treatment will be steroid or other immunotherapy. Therefore, it's important to recognize this etiology early and treat with steroids even before the antibodies results came back. Regarding the second line anti-epileptic drugs for status, as I mentioned, in the suggestive protocol, levetiracetam was recommended. However, sodium valproate can also be used. In this New England Journal paper on status epilepticus published in 2019, which compared these three agents, I would like to highlight two key points in this paper. The first one is the dose used for sodium valproate is 40 mg per kg. In the old protocol, the dose recommended is 10 mg per kg with an infusion rate over 1 hour. However, in these studies, the dose is 40 mg per kg, and in University Malaya, we usually start with 20 mg per kg. If the seizure is not controlled, we can add another loading dose of 10 to 20 mg per kg subsequently. The second point to highlight in this paper will be the infusion rate. The medications were given with rapid bolus up to 10 minutes in this study without much increased adverse side effects. And therefore, it is important to remember that in status, it's best to give as high dose as possible with as fast as possible infusion rate to achieve the seizure control. How about labor? 1 to 2% of epileptic women suffer a generalized tonic-clonic seizures during labor. Why is it such a low incidence? In fact, for those with uncontrolled seizure, many of them are not married. Secondly, if they are married, they may not want to have children. Even if they want to have children, the pregnancies or fertility may be affected by the seizure or the anti-epileptic drugs used to control. And therefore, for those who manage to achieve a pregnancy, the incidence of generalized tonic-clonic seizures is low during labor. For the management, we should continue the anti-epileptic drugs as usual, but if IV formulary is needed, these are the ones that are available in Malaysia, including phenytoin, sodium valproate, levetiracetam, or IV midazolam, or diazepam. We used to have IV lacosamide, but now it's no longer available in Malaysia. Besides that, we should try to reduce the triggers, especially pain, by considering early epidural anesthesia. For those with uncontrolled seizure, we should consider elective cesarean sections early. If a seizure occurs during labor, then a cesarean section is indicated. How about postpartum phase? In postpartum phase, the anti-epileptic drugs dosage should be continuous as it is, except Lamotrigine. If you have increased Lamotrigine during the second or third trimester just now, it should be reduced back to its previous pre-partum dose. Usually I'll do it within 2 to 4 weeks after delivery. Breastfeeding is overall safe. In fact, the breast milk secretion of the drugs is inversely proportionate to the protein bindings. And we know that sodium valproate and phenytoin has high protein binding and therefore is hardly excreted in the breast milk. But I'd like to highlight levetiracetam, which is having a low protein binding and the secretions in the breast milk is high. Therefore, if an infant becomes sedated or hypotonic with breastfeeding, especially on those medications secreted in the breast milk, then we should consider reducing the breastfeeding frequency or supplement with bottle feedings. Postpartum period, we should always try to avoid triggers which commonly happen, including sleep deprivation, stress, and pain, especially if the main caregivers is the mother herself. Therefore, we should encourage the mother to have supports from other family members, including their parents or at least their husbands. If they are the main caregivers nursing the baby, they should take special precautions, including nursing the baby on the floor, use shallow baby baths, and etc. to ensure baby safety. So in conclusion, I've tried to elaborate what we will do in neurology for women with epilepsy, especially from their preconceptual phase to the postpartum stage. Thank you very much.